So, comparators, a bit more about comparators. The comparator for the technology that's being assessed is very important. It's very important because depending on your comparator, this will to a large extent determine your incremental costs and your incremental benefits. Or in our case, incremental benefits might be the incremental QALYs. The additional QALYs you get, or quality adjusted life years, the additional quality adjusted life years you get from the intervention. Now, if you choose a comparator which is bad enough, you can make your intervention look very good. And this is not a trivial problem because our manufacturers of new drugs are very keen to show how good their drug is, and so they may well try and compare to something that's not too good because it makes their product look much more attractive. There's a number of considerations to be made when you're thinking about suitable comparators. An obvious potential comparator might be routine clinical practice. Routine clinical practice. And in many cases, it is the obvious comparator because you've got some new treatment that you're thinking of introducing. And so what to compare it to? Well, let's compare it to what we're currently using or doing for these patients. That sounds very straightforward, but it's not always the case that we know or we can identify routine clinical practice. You think it would be straightforward, but sometimes it depends what part of the country you're in as to what is routine practice. It can vary. I'll give you an example. If we're looking at treatments for early stage prostate cancer, depending which centre you go to for treatment, you could be more or less likely to receive perhaps a surgical intervention. Some centres will be more likely to give you drug therapy. Some centres might use brachytherapy or other technologies. So the answer to the question, what is routine clinical practice for early stage prostate cancer? There's no simple answer. It depends which centre you go to. Another consideration in choosing comparator might be cost effectiveness. You should never choose a comparator which itself is not cost effective. I'll say that again. You should never choose a comparator which is not cost effective. Because if you compare a new treatment, to an existing treatment which is not cost effective, you haven't really learnt very much. You might learn that the new treatment's better than the old treatment, but if the old treatment itself was not cost effective, was not a good use of resources, so what that the new one's better? It may make the new one look cost effective, but it's cost effective compared to something itself which was not cost effective. Sometimes, perhaps the most appropriate comparator is natural history. This would be a situation where the condition that you're looking at, there isn't really currently any suitable treatment. And so, most appropriate thing is what happens if the patients are simply left with that condition. What is the natural history of it? Sometimes it's argued what you should look at is what is expected to be replaced. So compare your new treatment to what you expect would be replaced by the new treatment if you were to accept the new treatment. As I said, routine clinical practice is a very strong candidate as a comparator, but it's not going to always be appropriate. For example, it might not be best practice. There's a condition called hyperuricemia, which involves acetic acid building up in your joints. And what happens is crystals form, and crystals in your joints can be very painful. The general condition is sometimes called gout, but hyperuricemia. Now, if these crystals are not prevented, if the buildup of acetic acid is not prevented, it's going to be quite painful having these crystals in your joints. And if it's left over time, it can cause major tissue damage and longer term disability. So in that condition, what is routine clinical practice? Well, until recently, the routine clinical practice in England was to give a particular drug. I'm going to try and struggle to remember the name of the drug. It'll come back to me. But to give a particular drug, I think it was a 200 milligram dose. That was routine clinical practice. But it's not best practice. It's well established that best practice is to start by giving a 200 milligram dose to these patients, but then up titrating to a bigger dose if it's not working. Up titrating as far as 800 milligrams. And if you do that, most patients can tolerate the stronger dose. And for most patients, if you increase the dose enough, it resolves the problem. But it remains true that the standard routine clinical practice is to give a 200 fixed dose. So you have to be careful. What is routine may not be best practice. And so then there's the issue, should we really compare to routine practice, or should we be comparing to best practice?